In many cases with pseudoexfoliation, there's no real evidence of zonular weakness intraoperatively, and yet you're still concerned about delayed postoperative zonular weakness, particularly with capsular phimosis and capsule contraction. So my preferred IOL is a three-piece acrylic IOL in these cases. The haptics have a little more compressive force as opposed to their single-piece counterparts. And with the acrylic material, there's less anterior capsular fibrosis and contraction compared to silicone. In this case, I'm secondarily enlarging the rhexis. I'm actually trying to tear it out to the very edge of the optic. In this way, with a large diameter and without much contact with the optic, there's very little tendency for contraction of the rhexis. I think the real lesson is you don't want to leave your rhexis too small because that will encourage contraction. And if you have slight weakness to the zonules, you don't have enough centripetal pull, you will have contraction. Now, there are alternatives. You could just take some scissors and maybe make some little tiny relaxing cuts in the edge of the rhexis. You could do this early postoperatively with the YAG laser if you saw contraction. Again, I think in terms of the long-term risk of a weakening of the zonules due to the contraction of the rhexis, in a case with pseudoexfoliation, I prefer to just secondarily enlarge it as I'm doing here. And although I don't have 10 years studied follow-up, you can really see how quiet the capsule is when you leave the rhexis very large, and you can see this a few months later.